Okay, so Ted did cover a bit of introduction on osteochondritis dissecans as well. So here I am. I will give you outline. The talk will be the what, who, and where, and how, and all that, and then I explain the clinical cases to you. So the reason I give you the initial very 4-minute talk so that all the audience, especially younger members, will have all on the same page with the faculty. All right. So classically, it'll be like that. There's a text patient with a classic cartilage, OCD lesion. And remember, what is OCD? OCD is something wrong with the subchondral bone and then gives rise to the instability of the adjacent cartilage. It's not something wrong with the adjacent cartilage. And you can see that a lot to do with blood supply there. And who gets OCD are the people actually around physis close in very young athletes. And where's OCD? Classically would be in the lateral aspect of the medial femoral condyle, because some of them also can be a small portion in the lateral side. And why do we treat OCD? Because you don't end up like that. A patient does become all fibrous and end up like huge lesion, end up poor young person at 15-year-old became osteoarthritic. Okay, so that's why I try to catch them early. So how do we treat them? I'll be asking a lot of the audience, the faculty during the cases. I'll give them always 4 options. You cast, you drill, and drilling you can be retro or transarticular, which I explain more, or you fix the fragment, and finally we regenerate allograft or ACI. So how do you evaluate this? You do X-rays, and X-ray can be plain AP and lateral, but a lot of time you can use tunnel view to help you. And nowadays, a lot of time you do a EOS or long film to look at whether there's genuvalvular variant, because you may have to add on that to correct your OCD. And MRI is very useful, and I will give you a little bit classification of MRI. When you read MRI first, you must look at the size, AP and lateral. And then this term about parent bone, meaning the subchondral bone below, and whether the parent bone is good, is linear, and also the progeny bone, meaning the poor lesion. So you look at the lesion, is it fragmented? That gives you bad prognosis. And also look at the lesion below, are they, is the thing nice convex or off convex? So this gives you the idea of prognosis. And then also look at whether this intact or not intact. And another thing is where you see the fluid in between your progeny bone and parent bone. Okay, so these are the things that you must try to look at them. That's why you always do fat suppression T2. That's a must. Minimum you must always do. And then this is a test patient. Dr. Ganley's patient can show you that if you get a fluid and high signal line, that show you unstable lesion. Okay? And then arthroscopy is very important to assess what you have seen on MRI. So further classification by the ROC group, research on OCD, we put in there immobile, which otherwise called stable, or the fragment become mobile or otherwise unstable. And even unstable mobile, also you could look at it, is it salvageable or not, meaning can I is it fixable? So this is a very nice classification, guide you in your treatment. And finally, it'll be a big crater, and then unsalvageable. So I tend to use these to guide my residents in the treatment of OCD. So this is the ROC group's nice thing that Ted showed earlier on. First thing is called cue ball, the immobile lesion, or sometimes a shadow. These are all nice ones, doesn't move. Then come to this, no good, it start to move. You see that? It's called trampoline. So later I will show you how trampoline like you poke and then the whole thing bounce up and down. And another mobile lesion called locked door. The door is locked, there's no hinge. And then later, this is hinge where you can see on top and below you can open the fragment. So these are mobile lesions. They're also called unstable. And then this is manhole, also very unstable. But all classified under mobile lesion. And then the last will be crater. Whole thing come out, the whole piece came out. So you can see whether this salvageable or unsalvageable kind of thing. Okay, so this is what Dr. Ganley showed you, like on top immobile, below mobile. And then non-operative treatment, which we don't concentrate on, but Ted has a nice thing about what are the points, like how long you treat, how bad the symptom and all that, which I think hopefully we get some time later to cover, because we are obviously here more interested in how you treat them operatively. So this is very important. The drilling, okay? So this is Dr. Ganley's picture. First, you go, from here, that's called antegrade, like going forward, go to the joint, to the lesion, and this is called retrograde. But this term today is used less and less in literature because the problem is a lot of OLT lesion, the lesion in talus. So talus retrograde is going backwards, antegrade going forward, then it's all upside down. So therefore, try to use a term called either retroarticular, you shoot away from the joint, then go into the joint, or you call it transarticular, you are shooting from the joint. So these are the terms that you try to use from now onwards when you teach your residents. So retroarticular or transarticular. All right, then maybe Dr. Ganley, you can tell us about when you drill your K-wire, how you get your K-wire trajectory better. Okay, so now if it become mobile and unstable and you fix, and this is where I ask Chital about, North American, they love to use intra-articular screw, and most of in Asian practice tend to use more of the absorbable pinning for different preference. And sometimes in very chronic lesions where you find that if after clearing, especially the subchondral bone plate and also the underlying surface of cartilage, in order to fix back, it's really difficult without some stimulations. Therefore, you may put bone graft, autogenous bone graft on top, and then after that you fix that. Okay? Then finally, really the big crater, you cannot salvage. Therefore, you can do frozen kind of allograft in North America, or in my context, I have labs so that I can grow cells and fix them back as well. Okay, so those are the things, and now I don't need to do work, and now my panel will be doing the work. Okay, first, this is a 14-year-old boy. I think my fellow then was treating with me. YY, a great boy, is a competitive swimmer. Okay, so pre-op, again, pain for about 9 months, and we actually, okay, so this is a lesion we saw, and then this pre-op lesion, and sorry, it's a bit overexposed, but nonetheless, I don't know whether you guys can see some of the thing. Okay, so sorry, give you how. Ted, you start.
So, favorite treatment methodology?
Oh, sorry, cast, drilling, fixation, regeneration.
So, for this patient, so patients with wide open physes,
boy,
I'm perfectly willing to start with non-operative treatment. If I see a fissure, if I see a transverse black line across the cartilage, a dreaded line there, then omen sign we'll call it, then I'll be more inclined to treat them surgically. I'm willing to give people the benefit of the doubt for non-surgical treatment. If I see breaks in the cartilage, it's always surgical. If you've already treated them 3 months, then I bring them to the OR. But otherwise, I'm willing to treat them conservatively for a trial.
So I tried him for 3 months of bracing, and I didn't put on cast. I put on a sort of lock brace. Yeah, but unfortunately, it did not relieve his pain. Plus, he's actually a competitive swimmer, so he really want to compete. So therefore,
yes. So then. An unloaded bracing, perfectly reasonable, or bracing, hinge brace, locks and extension, perfectly reasonable. And then at that stage, as long as it's intact, I don't mind drilling. If it's very soft, then I'll add resorbable chondral darts to support that.
Okay.
And so if there's breaks in it, then I'll add bone graft, but if there's not a break, I won't.
Okay, so therefore, what you suggest is perhaps a drilling, so you probably do a retrograde drilling in this context?
Trans or retro is totally fine.
You want to do trans here?
Either way.
Yeah, either way, okay. So you do that drilling and may or may not adding onto the darts, okay? So here we are, that's exactly what we did, and fortunately he was still in the sort of shadow phase, not even mobile at all, so I could do that, And I didn't have picture to show you, but this is what we follow up actually 9 months later. So what do you think here? The lesion, and this is the latest. And by this time, his symptoms all relieved, as no effusion, and now 3 months after this MRI, he's actually back to his progressive competitive swimming. Shitao, any comment?
No, you did retrograde drilling?
Yes, I did retroarticular drilling.
Yeah. Probably that is what I would have done. Couple of things is that I always get full length X-rays on OCD, because if they are loading in the same compartment with open physis, you have a chance of doing growth modulation.
Good.
Otherwise, you'll end up with a big osteotomy later on if they have, if it fails to heal. So I would take that opportunity, especially if I'm doing surgery and they have the OCD in the same compartment that they're loading, then I would like to offload it by a transphysis screw. Yeah. And the second thing is, a lot of times I would, with the retrograde drilling, I would put, insert bone graft behind it. So it doesn't take us too long, because we use the bone marrow biopsy needle to take, percutaneously iliac crest course, and we'll just insert it behind.
So the panel has jumped ahead on my case 2, case 3, where, there's EOS look at the alignment and also the bone graft, the bone marrow aspirate cases. Okay, so this patient did quite well. So next patient, so you can see Singapore is very cosmopolitan. A French girl, 14-year-old, pain both knees, but we concentrate on the right. Here's the X-ray, and alignment was reasonable. And this is the pre-operative picture. So, Dominic, you'd like to comment on this? Yeah. So again, same question, and she is definitely because she really had pain for a while, so really wanted something treated. So
James,
what do you think?
See, the MR shows a break in the articular cartilage. That's most important, I think. A break in the articular cartilage commonly signifies an unstable lesion.
So you think that is already there's articular cartilage disruption?
From this image, that appears. There seems to be a break.
Correct.
In the articular cartilage. So if that's the case, then this conservative treatment may not be the best option.
Yeah. So what would you do?
So in this case, at the time of arthroscopy, I would decide whether this fragment is mobile and how unstable it is. If it's relatively unstable, then I think fixation would be necessary, either by one of the Herbert's headless screws. I think that's the way to go.
Ted, what will you do?
And I would say I agree that based on this MRI, it looks to be broken through. Sometimes I'll put the mouse on the computer and go up and down, and it sometimes remains to be seen. I feel like MRI is more of a dynamic study to evaluate. But we'll say if it is broken through, then I agree 100% with fixation. I use the same form of fixation. If it does happen to be intact, you can add retroarticular and/or a little bone grafting from behind.
Okay. All right. So I move on here. So interestingly, there's no trapdoor, or it's actually just purely trampoline, which I'm surprised. Shita, are you surprised that you don't see any break in the articular cartilage?
Yeah, no, I'm surprised, because based on the MRI, I would have thought that there might be a small hinge somewhere. The cartilage may have been broken through, but it's not. Yeah,
so it's absolutely trampoline here. Therefore, I did a drilling plus add on DBX and with the bone marrow aspirate. Yeah.
Was there an interval between the MRI and the arthroscopy procedure, or was it done within a?
Probably about only 2 months interval, not far apart. Yeah. So I'm very surprised. So I showed this to show the panel that sometimes the MRI did not correlate so well with our arthroscopy picture.
That's kind of what I meant. But when you go up and down with the MRI, sometimes you say, oh, the cartilage could be intact there. And so that's why I feel like MRI is a dynamic study, and sometimes that can be intact when it looks initially not.
Yeah, so this is really sort of like a very, very nice, trampoline thing. You poke, it's really soft, and of course, perhaps in this case, like I could have done what Ted suggested. Maybe I should throw in the dart, because for follow-up, even with DBS and all that, the results are not as nice as I like to be, and she still have, she had no effusion, but she couldn't tell me a pain, but she couldn't really return to the level of activity she'd like to have. Any comments, Shita?
No, I agree, but I would try to fix it as well. I mean, stabilize that piece, even if there is no bone behind it, like the bone that you can see. Putting 1 or 2 fixation point just stabilizes the lesion, I think, well enough for it to heal. Yeah. So I would do the same thing, but add a little bit, maybe 1 or 2.
Yeah. So what I did was I thought I pushed, lots of DBX and with bone marrow aspirate and all that to sort of fill up that. So instead of putting the dart, fixing it, I thought I packed the empty space because it's still a trampoline. So by right, trampoline is elastic, so I can pack more things. But obviously, oh no, time's up, is it? Is it time's up yet? Oh, 1 minute. Okay. So let's move on quickly. So this patient, all right, very interesting. So you can see that what Chital mentioned about, so there is 6-degree varus, and there's a lesion on the medial side, all right? So there you go, Chital. Will you do a growth, but couldn't do growth modulation?
Yeah, no,
quite old.
I would have very low threshold of doing an osteotomy. If they are loading in the same compartment, even the best procedure that you do for long term, I think if you can put them out of varus, I think that would be.
So this case,
helpful.
I discussed with Ted, Kevin, and Jim Carey. And 2 out of 3 of them say, James, just add in the osteotomy. So I offered to parents, another French parents, and they agree. But on the week before the operation, they say, no, I think we just do with OCD. Yeah, they did read, yes. So realignment and not realignment. Okay, so again, surprisingly, that lesion, you just, you see, look at the arthroscopy here, and can you all look at the eye? It look pretty empty here, but you see it's just more shadow rather than trampoline. So it's, again, I found the X-ray and arthroscopy did not correlate as well as what you think. Yeah, so this is a post-op film, and then you can see that it's actually reasonable, and she had absolutely no pain after that. And the fantastic thing is now she's old enough, and she became a medical student in Paris. Yeah, she's back to the country. Okay, let me quickly I will skip the next case and jump to. So this case again, just a quick show you. The lesion here. Yeah, there's like a locked door. You can see the lesion here, but interestingly, it's locked door, but it's very hard. So it's not as mobile as what you thought we can probe it. So in this case, I did the bone marrow aspirate and drilling, and it did very well. And I think the quality of the cartilage when you probe probably means a lot, even though you see a so-called locked door kind of phenomenon, supposedly mobile, but they are not. Okay. So last case, this horrible. Megan, you look at this. Dominic, for you, look at this horrible MRI. Horrible MRI. Horrible. Okay, what do you think? What do you see here? I just give you this piece. Can you see that?
Mm-hmm. I think on this MRI, the fragment looks as if it's totally unstable. There's fluid behind the fragment, and I'm sure at the time of arthroscopy.
It is more than omen sign, is it, Ted? More than omen, all the devil came out already. Is it? Yeah, so.
Right.
So what do you do?
So at the time of arthroscopy, see how large the fragment is. See how viable the surrounding tissue is. If the tissue is good, you probably have to opt for one of the transplant, maybe the chondrocyte transplantation, or maybe the oats or whatever. Yeah.
So that's exactly I told parents, and then you can see this really open up lesion. So your scope, is very overexposed. It's really deep into beyond subchondral. And then this big crater, like what you say. And this is my, I call it arthroscopy picture, but it's no, basically, Chital is a dry arthroscopy, and I put in my scope to look. And because the base is quite vascular, so I went to clear more. I basically dug up everything below, and I actually went to do a bone graft, and because I thought below the cartilage piece still had a little bit of bone left, and I went to fix it with bone graft. So this is what it's like 2 years later. Not fantastic, but Ted comments.
I think that looks fantastic considering what you started with. You know, you've regained better subchondral bone base, and there is cartilage covering that area. These can be the incredibly bad actors and very difficult lesions, and I agree 100% with Chital's points about alignment for these are critical as well.
Yeah. Chital, will you just throw that piece away, or will you fix back like what I did?
No, I would have done the same thing what you did.
Okay,
you know,
good.
we have fixed like loose craters or loose bodies even 1 year out. You know, and it's amazing the ability to heal, because you know I have not done a primary osteochondral allograft. It's always been a salvage after failure of the first procedure. So I probably would have done the same thing, unless it's like, you know, you don't have the piece, then you don't have an option.
You know, I mean, a lot of you know that I'm a tissue engineer, and even I grow all the cells in the lab, but I found nothing I grow can ever replace a natural human bone and cartilage. So I always try to salvage things. So summary, I think I don't summarize anymore. So just a bit of advertisement that we are going to show all these even in the Singapore meeting, and next year we're going to demonstrate all these in the cadaver, and Ted and Shita, all that will be helping us as well. Okay, so thank you very much for your attention.